Listening in on our YouTube feed and our YouTube recording. We are behind the scenes with our exceptional panel right now. We're getting ready to get started in about 2 minutes. Bear with us as we kind of get things going here. Listening in on our YouTube feed and our YouTube. That's why I start the recording. All right. Awesome. All right, folks. We are great shape. We got about 90 seconds and we'll be right on time. All right, understanding that this is being recorded on YouTube, but is there anything else that we want to kind of talk about before we kind of jump out of the plane here? We're good?
I think we're good.
Okay, awesome. Have fun, be informal. If there's something that you can't answer, then
Hunt.
you just
Hunt.
Just tell me.
Good.
Just tell me. We don't want to. There's no gotchas here. We just want to, provide value.
I'll kick one of my dogs so they bark.
Lisa, too, if you want, you'll have access to the Q&A. I usually sprinkle in live questions through the show. If there's something you rather just address through through individually answering it in writing to that individual, let me know through chat, and I won't ask it live on the show.
Okay. Sounds good. I'll keep an eye on the chat.
Yeah, both everyone could just make sure when you're chatting with me through Zoom that you're not sending it to all the attendees.
Private.
Right. Private is. If you have any applications that are going to pop up here or anything like that, this would be the time to shut them down or mute them or whatever you need to do.
Done.
All right. We are going to go live now. Greetings, everyone. Welcome. This is Eric Glazer, and this is your live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also, most importantly, unearth bright spots, successes at health plans, at healthcare delivery systems, at hospitals and other healthcare organizations around our country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on our show can be applied at your organization. We believe that this approach in finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you have not yet subscribed to Bright Spots in Healthcare, it can be found on most podcast apps where you consume podcasts. So please do subscribe, rate, and comment. Our topic today is a very important one, especially in today's climate. It is entitled Innovations in Physician Engagement and Provider Learning. And we're going to discuss approaches on how to ensure our practitioners, the ones we trust with our lives, are as current as possible with the best treatment practices available during this unprecedented healthcare crisis that we are all living through together. We were able to pick this programming through the incredible support of all of you. And we know that we don't charge you a registration fee to attend, but your participation enables us to handpick specific organizations who can both support our programming, but also add to the robustness of our discussions. The sponsor of today's episode is an organization called Knowledge to Practice, or affectionately called K2P, and they are one of the innovators and bright spots in our business as it relates to personalized provider education. They have created an innovative digital platform that personalizes learning based upon the current knowledge and the attention span of practitioners. The platform enables physicians and other providers at hospitals and healthcare systems to do a better job providing the most effective patient care. This is going to be a super exciting discussion. We have an incredibly accomplished panel, and I encourage you to, if you're listening on recording, to go to Shared Purpose Connect and click on past recordings and click on their bio page so you could get a sense of the expertise and knowledge you're about to receive. For those of you who have logged in live, we're going to post a link to their bios in the chat. But we do want to get into our discussions so that we could address as many questions that we've planned for them and many questions that you may have for them in the hour that we have allotted. There's a Q&A module at the bottom of your screen. I have it on a second screen. That's why I'm pointing off camera. And if you want to click on that, you could ask questions to our panelists throughout the show. I'll try to integrate them into our live discussion. Some of them may be answered just via typing an answer to you. But please do use the Q&A module and not the chat button, as it makes it much easier for our producer Sherry Keels and I to manage the queue. All right, here we go. I'm going to start off with the CEO and founder of Knowledge to Practice, Mary Ellen Beliveau. And if you are not familiar with Mary Ellen, she is a visionary in the world of continuing medical education. She's got an incredible, inspiring personal story that she will share with you and can tell a lot better than me. But in brief, she spent a half a decade at one of the leading CME companies in the country called Pri-Med as their EVP of Specialty Services, then spent another 5 years as the Chief Learning Officer at the American College of Cardiology. And she's also, is it chairman of the board at the community hospital? And
At Suburban Hospital.
There you go. In the DC area, right?
And then I'm on Hopkins board as well, yeah.
I didn't know that. Okay. It's fantastic.
Learn something new every day.
There you go. So Mary Ellen, why don't you start and what inspired you to get into medical education? Why are we all here?
So when I was delivering my first child who had exceptional difficulties in the hospital, she actually ended up 2 years later being identified as a child having Noonan syndrome. So the first 2 years of her life, we were in and out of the hospital, major hospitals in the Boston area, top hospitals in the country. And as you can imagine, you get very close as you turn your little baby infant over to providers. You get very close and you recognize both the excellence that they have, their incredible commitment that they have, and the passion and love that they have for your child as they develop relationships over time. And through the process, as you can imagine, there were lots of mistakes made, and the mistakes weren't made because of lack of excellence in any way. I revere her providers. I'm thankful for her life for her providers. But regardless, we went through 2 years of lots of interventions, some that were unnecessary and made things worse, and some that saved her life. And that process and the passion that I gained for her providers, both NPs and MDs, and including her ultimate heart surgeon, it really made me realize that I needed to dedicate the rest of my life to ensuring that I would be committed to getting them the tools they need to practice at top of license. And so, you know, you identified how I've moved through my professional career. And then ultimately, as credentialing became a high stakes game, and the rate of development was literally outstripping physicians' ability to keep up, I chose to leave ACC as the Chief Learning Officer and start Knowledge to Practice with the goal of recognizing that education and the tools that physicians need to stay current need to be drastically different in order to support the delivery of value-based care. So I started Knowledge to Practice in 2014, really out of my experience with my daughter, who now is 22 and studying to be a nurse practitioner down at Belmont University.
That's great. And kudos to you for your bravery and jumping into the world of entrepreneurship to get this done. I'm sure if there's clinical leaders on the call, they're thinking to themselves, all right, well, we all have subscriptions to UpToDate. How is K2P different, or how does it kind of hook in with UpToDate?
Yeah, I think that's a really, really great question. I think UpToDate is a renowned resource and a very helpful resource. We really think we're a good partner to UpToDate in many ways. UpToDate sort of gives you the what, and we consider ourselves as providing the why. So more broad education and helping physicians to self-assess where they have and lack mastery, and enabling them to access the insights and information that they need to be at the top of license while they're practicing their care.
That's great. Questions in the Q&A module. I'll continue to remind folks about that. Also at 2:45 East Coast time, you'll receive an email from me asking for your feedback on this session. We choose our topics exclusively from the voice of all of you. Those who are regulars who attend this show know that. So we use that 2-minute multiple choice survey that we'll be sending you at 2:45 East Coast time as a way to plan our programming. So we ask you the favor in advance of completing that, and we'll continue sending it to you. So you don't want any emails from me if you don't complete it. I'm going to bring in Dr. David Nash. If you do not know David, and you probably do already, at least know of him, he's the founding Dean Emeritus at the Jefferson College of Population Health and was the Dean there for 11 years. He is also a board-certified internist, internationally recognized for his work in public accountability for outcomes and physician leadership development. So David, how, from where you sit, how do you create a true peer-driven engagement and training program?
Wow. Well, first of all, Eric, thanks again for having me. And it's just wonderful to be a part of the K2P family. And Mary Ellen really is a visionary. And that's why I decided to get on board and help sort of spread the gospel, if you would. And it's very consistent with my 30 years on the faculty at Jefferson in downtown Philadelphia, in terms of trying to find all the necessary tools to try to change doctor behavior. And as most of our listeners know, that's like pushing a giant rock uphill. So you can get all the evidence, but what I love about K2P is the follow through, the thoughtfulness of the content, and the ability to bring all the tools together to help doctors do a better job. That's really what it's all about. So the physician engagement here is not just, here's the content and we wish you luck, and how you internalize and use it is all still magic. That is not it. It's, here are the cases and here are the learnings. And then what I'm trying to bring to the table is, here's how we use the information in everyday practice to drive improvement. And here's the change management that we need to drive improvement. And here are the tools and skills from population health and performance improvement to drive improvement in outcomes. So I'm kind of the little bit of the go-between between this amazing content and then actually helping the docs to achieve an improvement in outcome. And I'm bringing to bear my 30 years of experience in trying to do this. I wish that there was a silver bullet, Eric, but Mary Ellen's tools are about as close as I have ever come to seeing we'll call it a bronze bullet instead of a silver bullet.
And so, and even just in general for folks that, are just trying to figure out ways of doing a better job supporting their doctors, sort of product agnostic, so to speak, David, how do you gain the perspective of a physician, and how do you inspire their participation in new education when they're already kind of obviously busy running around the hospital?
Sure. So, every single doctor I've ever known, including my wife and daughter, go to work every day wanting to do a better job. What they're surrounded by is system failure. So electronic medical records that take too darn long, laboratory results that don't come back, dictation that fails, a schedule that's too busy, all of the above. It's no wonder that we have unbelievable burnout, and why we had to create the fourth leg of the triple aim, and, and on and on. And in the post-COVID world, triple what I just said. So helping to create and disseminate a tool that gets us to the best available evidence in an easy to digest way, and that has take-home messages that are immediately clinically relevant. And then we add the tools on how to put it into practice. That's the secret sauce. So we're in a very tough time, not just economically, but psychologically, as you alluded to. And so to find a tool and a toolkit that enables us to take the best available evidence, so we don't have to run around trying to find it, and then apply it in a way that actually improves outcome, well, that's what this is all about.
And, in the spirit of sort of sharing examples or bright spots, are there any organizations around the country that, you think are doing a better than average job in just providing education and content to their providers?
Wow. Well, I'm going to ask Mary Ellen to take that one first, then I'll give you my perspective.
I think that's a really interesting question, Eric. I think specifically physicians a little bit more so than APPs, but they're really accustomed to turning to their academic medical centers and in addition to that, obviously, their medical specialty society. Those remain to be some of the largest providers out there, as well as publishers of products, of which Up to Date is produced by Wolters Kluwer, right? So I think the interesting thing is, as you start to look at those worlds, they're still largely siloed. So the concept of creating curriculum and access to an interdisciplinary team and thinking about it across the care spectrum. So thinking through the patient's lens instead of the educator's lens, or instead of the physician subspecialty lens, you really start to think about how they need to think relative to their profession, relative to their role, relative to the stage of care that they're delivering, what their responsibilities are there, and what their responsibilities are relative to the transition of care to the next stage, whether it's acute to inpatient or inpatient to outpatient, and keeping those communications. And what I don't see is anyone out there thinking about that, which is what we're talking about, right? I don't see people thinking about that. I still see people thinking about the competencies of a neurologist and delivering curriculum against that, and thinking about the specific competencies to a specialty area rather than thinking about a full comprehensive team of providers working together in an integrated fashion, looking at those issues that are really big blockers for the delivery of value-based care and making sure they have the right education based on their needs, based on their care setting and their clinical background. And talking about things like heart failure and sepsis and those big causes of mortality in our country and cost drivers in our country. And we're not doing enough. Us as educators, we're not doing enough in providing the right level of education to the right provider with clarity of the spectrum of care which they deliver.
Hey, Erica, Mary Ellen gave a great answer. So I would say, let me change your question a little bit. What's the research evidence as to what kind of setting promotes the best doctor learning? I mean, that's a really key question, right? So what do we know? Lots of research on this from 3 decades, people like Steve Shortell and many, many others. So what are the organizational characteristics that predict a good clinical outcome? Multi-specialty groups that are doctor-driven, like Everett Clinic in Washington State, Mayo, Oxner, where the doctors feel that they have a role and active participation in the goals and objectives of the organization. They're not just an employee. 35 years ago, I coined the term white coat, blue collar, which is docs who are employees and aren't participating in the decision-making process. Well, they're never going to jump into a K2P type world and really get engaged because they are not driven in the culture that they're working to excel and integrate the best available evidence on a day-to-day basis. What else do we know? Where doctors are in teams and they're questioning each other every single day, as you alluded to in an academic medical center, well, the free exchange of information, the back and forth, everybody's on his best behavior. Young people are asking amazing questions. Having been an inpatient teaching attending for 20 years, I can tell you that, these young doctors are amazing because they grew up with the world's information at their fingertips. They're going to be stimulating faculty members every single day. The days of let's look it up and we'll talk about it tomorrow, they're long gone because everybody in 2 seconds has the answer on her cell phone. So we have to be able to be agile and have cases that are really sticky and create a lot of traction, and that there's a excitement about getting to the end of the case and then understanding how we could take that information and implement it into our everyday practice. So organizational dynamics, effect, physician learning, and ultimately patient outcome.
Thank you for that. That was great. I'm going to bring in Dr. Dan Davis. He is the medical director at K2P. He's an emergency medicine physician, was on the faculty at UC San Diego for 16 years, has authored more than 20 peer-reviewed articles. Dan, could you give us some background on how the design curriculum in a platform like K2P, but just in general, what's important around designing curriculum for physicians, and how does that work with your research team? Like, how are you able to deliver that?
Yeah, so thanks for having me, and I appreciate the lead in from both Mary Ellen and David, because they really set the stage for exactly what I saw when I joined K2P less than a year ago, and came in with a fresh set of eyes and saw all of the things that they're talking about sort of living right in front of my eyes, where you have this team of academics who have a scientific perspective, along with thought leaders who have insight into value-based care and clinical practice, teamed up with this team of researchers and scientific writers. And so the process, which I saw from the very beginning, was unique, where these thought leaders and scientific leaders could give some scope, identify the areas that were most important for the learners to take home, and then set this team of researchers and scientific writers loose to cull the literature, do a complete surveillance, come back with ideas, with a product that was 80% of the way there, get more feedback, and then use leaders in the field to actually deliver the content, allow them to give their final polish and really own the material. And what ends up happening is that you have this sort of magical blend of the academic with the learning theory, but even some of the technological advantages that allow people to be met wherever they're learning, like David mentioned, that people can access information on their cell phone. And so we had to be adept and bring this academic flavor into a medium we had never really seen before. And it was that kind of magical concoction of elements that really attracted me to K2P.
How, and I'll throw this out, I don't know, Mary Ellen, if you want to jump in, or Dan, you want to stay on mic here, about how you are able to deliver this. Like, I get a sense now a little bit of how it's kind of all happening behind the scenes, but how are you able to deliver it on a timely basis and keep folks as current as they need to be?
Yeah, I think that's part of our special sauce, which is one of the things that we recognize is keeping up with the literature is virtually impossible. Like I said, the rate of development is outstripping physicians' ability to keep up. So what we do is we have those team of clinical writers and editors that are each charged to be monitoring what's happening in the marketplace and continually serving up. All of our curriculum is living, breathing, if you will, so that we're promising people that are on our products, we're keeping pace with the marketplace for you, so you don't have to keep up with the literature. So we are the ones this clinical team will monitor what's happening. We have regular sessions with the panel of physicians that lead and own each product, i.e. Dan is the chair for our COVID product, and he has a stack of faculty that he works with. So the clinical team will feed up, here's what's out there this week. COVID moves exceptionally fast, so the curriculum he's managing, you can imagine, is fast and furious. So the team serves it up. The faculty sit down and say, what's esoteric, what's critical, what's got to get out there. They prioritize it. And then we move through our process of every piece of content we have is accessible via video, via slide deck that you can download via MP3, so you can listen as you're running or whatnot, and transcript. So we move into the production of our multimedia from that, and then ultimately to the publication. So it takes us, we can do new content in as short as sort of 4 to 5 weeks and get it out there really rapidly from the moment that it hits the press, right? Whether it's coming through CMS or anywhere else, we're on top of it. And it's really the leadership of the faculty, but it's those clinical writers that are keeping pace so the physicians don't have to. And we're just distilling it down in as practical manner as we can, as small chunks, so their learning can be done while they're on the go, and have real quick access to it.
And Dan, how are you determining what is, from a medical standpoint, relevant for consumption, not relevant for consumption?
Well, that's, in my role with K2P, not only am I involved with the company as a whole, but for the COVID product, I'm also considered to be an expert in that field because I work with public health, because I'm in the emergency department. I oversee both helicopter and ground EMS, and have been part of our hospital's preparation. And so from that perspective, I'm able to decide what things are most relevant in any of those settings, and make a call as to whether it's something that needs to be inserted into the material immediately in a matter of days. So Mary Ellen mentioned 3 to 4 weeks, but we can actually insert key content or remove content in a matter of days if necessary, or whether it's something that we can wait for the next scheduled update. And we're currently going into our 3rd or 4th refreshing of the material just since April.
Mary Ellen, I'm going to put you on the spot here. Can we have people listening today get access to that COVID content for a bit?
Yeah, absolutely. Happy to do that. And one thing we haven't spoken a lot about is we've been really focused on learners because that's the topic today, but there's an interface obviously for administrators as well. So they can start to manage risk and better support their teams, right? So I think I think healthcare is remarkably behind in understanding they have a role in the development of their clinical resources and making sure they're providing the curriculum and content that is critical to that institution delivering value-based care. And that's that piece of it they wouldn't be able to see, but we can absolutely give them access to the learner perspective.
Cool. Why don't we do this, Sherry? Why don't we put up a poll for those of you who want to try out, we could call this a free trial, Mary Ellen, is that fair?
Yeah, sure.
Let's say for the month of November, if you want that content, I'm looking at my show notes here, 41 activities, 11 and a half CME credits. If you use all of it, you don't need to put a credit card in either, I don't think, right?
That's right.
So why don't we put a poll up? If you don't want it, you don't have to fill out the poll. It's right in front of you right now. If you're live on the show, just click yes, and we will get it to K2P. We'll get you registered, and you could be using the platform for the month of November at no charge and get all that updated information that Dan and Mary Ellen were just talking about at no cost to you. If you are listening to this on recording, why don't you go to sharedpurposeconnect.com and /K2P, and we'll have a form there, and you could fill it out, and we will get that information to the team at K2P, and they will enroll you in it. And in fact, if you just want an introduction to Mary Ellen or anyone on the team, just go to the sharedpurposeconnect.com /K2P, and I'll get that introduction personally done for you, and we'll get you signed up for the trial as well. All right, let's move on. So I'm going to bring David back into the conversation. David, did you experience the need for something like this, not only at Jefferson University, but also in your role as sort of a public health leader in the country?
Sure. Anything that delivers the best available evidence in an easy to digest way and is kept as current as possible, it's a fantastic tool. Listening carefully to this amazing conversation, I'm struck by 2 things. One, poor Dan trying to keep up with the hour by hour changes in COVID therapy. I'm glad it's not me, so thank goodness. And 2, I wish I had a tool like this, a decade ago. It would have been fantastic, for my own practice and for teaching purposes. This kind of technology and the understanding of the organizational culture and how you actually change doctor behavior. We've been it's fair to say we've been working on this for 3 decades. So yeah, I wish I had this tool a long time ago. It would have been fantastic.
I'm going to interject. I have another question for you, David, but there's a couple of questions coming in from the audience that I want to get to. Do you have any, and this is probably a Mary Ellen question or a Dan question, do you have any plans to expand into ophthalmology?
I was just typing the answer to that.
Oh, sorry.
We do, but it's actually not on our content roadmap until 2022. So it will sort of depend on the next capital raise that I do, and if we can pull it forward, we will. But right now, it's on for 2022.
Okay, great. Let me know, Mary Ellen. There's a couple of other questions in the queue, and I don't know if you're typing up answers to them. You just saw that last one that Kristen just.
We can talk about, if you want to do Tim Dudley, we could talk about that one.
All right, Tim, your number's been called. All right, how is educational content tailored to value-based care?
Yeah, really glad you asked that question, Tim, and David, I'll also turn to you to support me on this. But I think the first thing that what we're trying to do is make sure we understand the goals of the institution, which supports their ability to support their workforce in the right ways, and recognize that the delivery of value-based care needs to be aligned with the standards of care that that institution sets, and then the tools that that institution gives you so that you can deliver at those set of standards. So we're looking to be the ones that are, if you look at heart failure, the field of heart failure is growing at one of the most rapid rates out there. And if all of a sudden you're in the ED and they don't understand the difference between HFpEF and HFrEF and how they've sort of bifurcated that market, that's a concern, right? Like that's something that in a cardiologist mindset, that is like now a ground rule. Whereas in other markets, they're like, what's HFpEF and what's HFrEF, right? And so what we're trying to do is recognize, hey, you guys got to jump up to this. This is a thing, right? And the guidelines are getting updated. You might not live by these guidelines, but those patients are coming into your ED. And so really looking at those key topic areas, the COPD, the stroke, the sepsis, all hospital-acquired infections, heart failure, AFib. So looking at those key drivers of huge penalties that CMS is putting on institutions and making them struggle with, and being committed to giving high quality, easy to access, only do what you need to do based on where you're not up to speed right now. So you don't have to boil the ocean. You get small chunks that you personally need based on where you practice and how you service the patient at that point of practice. And so trying to make it efficient, gisty, and just what that individual needs, and have it align with the goals of the institution.
Gisty, I like that term.
Gisty.
Eric, let me jump in too. Mary Ellen did a great job. I would add this. So in a value-based world, what do we need to do? Well, we need to reduce waste, and we need to use resources in the most efficient way possible to achieve the best outcome. And that margin, well, that's what value-based care is all about. And good teams of physicians and nurses and others who follow this and can reduce waste, use the best available evidence, right drug, right patient, right time, no mistakes, well, they're going to have a better clinical outcome. Oh, and by the way, probably make more money. So this tool and the whole toolkit is actually really well aligned with the whole value-based payment agenda. But what are the characteristics? Teamwork, just-in-time training, closing the feedback loop, helping doctors to do a better job, which we all want to do, but we're thwarted by all the failures of the systems around us.
Okay. And I'm going to, Ellen, I think we then captured most of your question. If we didn't, go to the Q&A module and ask us a follow-up, because I think that captured most of it. I'm just looking at the queue right now. I think we're all caught up. That was great, although you didn't use the word gisty, David. All right, David, I'm going to come back to you. What is the role of the hospital and medical executives in ensuring that you have the local standards of care in place and support the team in doing so? Like, how do you gain a vision and how they're doing everything?
Yeah, well,
As a hospital administrator on the call today.
that's a tall order, right? So it sort of depends, I guess, on the organization. But look, again, I think every hospital leader, whether they're a clinician or not, wants to make sure that their organization achieves the best possible outcome. So, I haven't changed my story at all. So then I think convincing the leaders that they should pay for this tool and then disseminate it to the medical staff, well, that seems very consistent with what K2P's ultimate outcome is, which is best available evidence in a timely way, cases that make sense, and then teaching the tenets that we need for performance improvement. So the leaders, they're the ones who are responsible for helping with the resources, not only to buy the product and disseminate it, but I think setting the organizational standards and providing the resources to do the implementation. Let me give you an example. So, a forward-thinking hospital would want to have this product, give it to the appropriate medical staff, leaders. That's all great. But then they also have to make sure that they close the feedback loop to see, is it having an impact? And we are all measuring all kinds of outcomes. And so the key here is closing that feedback loop to make sure we're achieving an improvement. As Mary Ellen alluded to, heart failure, particular tough one, sepsis. I mean, despite a decade's worth of work on outcome measures and quality measures for these two really key areas, we've made only modest improvement. So it's a team sport. We need hospital administrators, nursing leaders, physicians, and the tool to really, if you would, move this ball down the field.
It's great. I got another question from an audience member. I'll throw it up as a jump ball. What are the most important success factors for physician training?
Wow. Well, why don't I go first? Mary Ellen and Dan, it's been fun working together, but you don't appreciate that when I got to Jefferson as an assistant professor of medicine 30 years ago, I was 6 feet 4 inches tall. And now I can barely make it to 5'6". So Eric is asking me a very sensitive question, meaning you could get worn down with a question like that, right? So how do we improve medical education? Well, that would fill the room I'm sitting in, right? So look, I think there's a couple of really important things. We need a new model for both undergraduate medical education, the first 4 years of medical school, and graduate medical education, internship, residency, and fellowship. We need a totally new model, a model that is all about lifelong learning, self-motivation, the tools to improve, and transparency of the outcomes we achieve, because everybody knows Dan and I are great. Just ask us, right? But in God we trust. Everybody else bring their outcome measures. So we need to teach all this. And I have spent a good chunk of my 30 years at Jefferson on this exact question. How do you get this kind of material into both undergraduate medical education and graduate medical education? It's an uphill battle. And that's because everybody wants his or own little piece of the curriculum to, have the top billing. So we're making some progress. Here's a good piece of news. My daughter's medical education, she's a young attending now, seemed in some ways very much the same as my wife and mine from 40 years ago, and in other ways, very different. And so there's opportunity for improvement, most especially closing the feedback loop to improve performance. My daughter had way more of that than I ever had.
You're a young attending too, David.
Thank you.
Anyone want to jump in and add to that? Or we?
Yeah, I mean, I'll add a couple of things. One, I think, I think that's one of the things we're not here to talk about today, but we have many products that are there for the training programs. And the goal is to think about those millennial and now is it Generation Z?
Yep.
I think so.
And how, you know, to David's point earlier, they were born with an iPhone in their hand. They're instantaneously gratified with whatever information they want to find. And so, you know, our goal has been to think about how can we augment those training programs to give the program directors more insights, more and high value insights through our administrator dashboards. But most importantly, what we do is we align with their rotation. So they take a pretest before they go into the rotation. So the attending of that rotation understands the baseline that's coming in, what concepts they're struggling with, and then can think really strategically as they're going through their rounds, why some concepts are tough for them, and can actually teach to the moment much more effectively because they have this data that takes them 2 seconds to look at. And then as they're going through their rotation, each of the people in the rotation have the opportunity to engage in those case studies that very much align with the patients that they're seeing. So when they're having their discussions while they're rounding, they have sort of this national curriculum from top thought leaders that they can say, oh, they do this, we do this. Because, and David, you're far more educated on this than I am, but when you think about quality improvement, probably 2/3 of it are all about process, but there's an important third about it that is about knowledge and skill. And if that knowledge and skill is off 1 degree, which is highly likely given the amount of administrative duties on an MD's plate right now and the rapid rate of development, if it's 1 degree off, no matter how great your processes are,
Right.
the practice will not be where the institution wants it to be. And so what we're a big believer in, and this is why I think, you know, David and we are excited to partner together, is they belong together and do it in a safe way so the provider can see where they have and lack mastery, and they can quickly, very accessibly get to the content that they need while they're on the go. We're not talking about board certifying them in heart failure, right? We're talking about giving them the piece that they need based on what they do. And that working together with the process improvement. If you talk to any quality group right now, you will hear at least one person refer to whack-a-mole. Sepsis is doing good now, and then it's like crap next week. And they just went through some process initiative. Everyone was paying attention to it, and they got everything under control. They switched their attention to something else, and God damn it, sepsis just went back up. Right. The education piece starts to ground those behaviors so they don't come and go like that. I don't need someone watching me wash my hands. Right. So, and I also think this concept of education coming outside the institution and coming from a journal or coming from a medical, the reason why we're trying to do this is bring it inside an institution. Let the institution provide these resources, let them have transparency about it, let them educate about where they can improve, let them see how they perform to their peers relative to education. They're looking at Vizient and Premier data relative to the quality, but they're not to the competencies of their physicians. They right. can be doing that. So we're just talking about bringing the two things together. And I don't, you know, I hope we're not the only ones thinking in this way. I hope everyone moves in this way and starts to understand that the observation part of education can only happen inside the institution. The institution doesn't have you know, adult learning experts, and they don't have an e-learning platform that's high powered to give them access on the go. They don't know how to leverage artificial intelligence relative to education. Right. They use it in a much different way. Bring in the experts to bring that and deploy it. We can then actually feed them a needs assessment on a quarterly basis on specifically you and your population and where you have gaps in knowledge and skill. And that needs to really empower the executives that David's talking about, is the ability to see they're struggling with discontinuity of care from one site to another. This is a tool that can help you inform. It's a different culture community hospital than it is at the academic. You can't force them to have academic protocols there. You right. have to understand their system and give them the tools that they need that align with the system, but it gets delivered in a different way, i.e. they don't have a heart failure clinic or
Right.
whatever the reason is. David, I turn it back to you, but
Yeah. So Eric, it's really sad that Mary Ellen has no passion for her work.
No passion. Actually, before you go, David, Mary Ellen,
Mm.
during your passion, just be careful. I think you're hitting your mic.
Yeah.
oh, sorry.
Getting a little bit of like
It's
broken
really
up.
sad, too bad she doesn't care about what she does.
Yeah.
So let me distill. I think I heard 3 really important messages that are worth reviewing. So indulge me for a moment here. One we already chatted about, which is the organizational culture and how doctor work is organized impacts patient level outcome. I want to make sure our listeners are sort of getting all of that. That is not a trivial connection that we're making. Let me put it a different way. How we are organized in our day-to-day work impacts at the patient level. So Mary Ellen is right on target. And again, one of the reasons I'm engaged with K2P is my belief that this is a leadership commitment on the part of the organization to provide this particular tool. So that's one take home. Second take home is transparency on the outcomes. So look, we all know, all of our listeners know, although it's not always something we want to chat about, you have 100 doctors doing the same thing. What do we know? Well, there is a bell curve distribution of their capabilities. And this goes to the great books by Atul Gawande and others, the book Better, the Checklist Manifesto. There's a huge literature on this. So if 100 doctors are taking care of patients with heart failure, 80 of them are doing a pretty okay job. They're going to do just fine. 10 of them are knocking it out of the park because they're K2P users. And 10 of them need remedial help on the Starling curves and all the rest that we learned in medical school. So, the message that there's uneven distribution of the skill sets and our ability to improve, that's the second take home. Third take home, which has been part of my work for 3 decades. How do doctors change behavior? Well, when they're given non-punitive feedback on their own performance in a timely way by respected peers, and the clinical data is severity adjusted, so we're talking apples to apples, and then we teach them how to improve, you need to get out of their way because they will stampede to do a better job. But that's a tall order. I'm going to go through that list again. Non-punitive feedback in a timely way with good information delivered by a trusted peer and the data severity adjusted so it's apples to apples patients, and then finally giving them the tenets of population health and performance improvement. You do all of that, then you get out of their way because they're going to rush to improve.
Let me catch me here because I try to get all of that. Non-punitive
feedback on their performance, right? Timely meaning I don't remember what I had for breakfast. So if you're going to talk to me about a patient I saw 4 weeks ago, forget that. And then non-punitive
data and info, right?
Good data. So, hey, what's the norm in our group for the treatment of heart failure? Don't tell me about 50 other hospitals. I mean, that's interesting. And if they were doing really poorly, I'd like to know. But what I really care about is my peer group, right? How do I stack up?
And trusted source that's delivering that.
Exactly. So look, I'm in a long time practice of really wonderful general internal medicine colleagues. I happen to be the oldest guy left. I know that I'm, in the wrong part of that distribution now, and my younger colleagues are amazing. So I'm going to need feedback on my performance to do a better job. And these kinds of tools that K2P's developed, that's part of this process. And then the final piece, Eric, which is, very difficult and requires organizational commitment, teaching those process measures and improvement tools, use of data. We'll call all of this performance improvement. And that's a big topic for another time. But without the organizational commitment, including, experts have talked about a measurement team, a time of the week when we sit down to look at how we're doing. Imagine if we took 1 hour a week, I'm just in a group practice setting like this, and we, how are we doing? That's an existential question, right? But here's the data, and here's the norm that we want to achieve, okay, now how do we get there? Well, that takes a skill set that most folks don't have. Improvement is gut-wrenchingly difficult, hard work, most especially for experts.
That's great. Mary Ellen, why don't I'm going to ask you one question. Well, I'm going to ask you two. I'm going to you're going to have to multitask. First of all, I want to ask this question from Alan Kearns. Does for-profit versus not-for-profit play a role in adopting a tool like this? And then my follow-up question to you is, look at the queue and tell me what other questions there you want me to address. I got about 3 more questions in my hand as well. So first with Ellen's question, then mine. Does for-profit versus not-for-profit play a role in adopting a tool like this?
It does not, no.
Yeah, boy, I hope not.
Okay, I'm gonna stall now.
I feel like there's a question underneath that, but if that truly is the question, no, there's no difference.
Maybe you could, Ellen, not Mary Ellen, but Ellen who asked the question, if you have a follow-up, we'll look at it. While I stall for you to look at the rest of the queue there, I'm going to ask you one from the queue here. How do you personalize content, especially as it relates to attention span?
Yeah, so something that we do very rigorously is an educational needs assessment, making sure we're really clear on the knowledge and skill gaps that exist and need to be solved in the marketplace. And we use a spectrum of people for that perspective. And we have a very rich way of getting at it. We don't have time for me to outline our process, but that enables us to get down to very specific learning objectives, teaching and testing points. In any given course, we're likely to have 200. And so you can imagine the ability, sorry about that. I thought I had shut that down. The ability to create micro learning activities that are personalized to each individual. The secret is having very clear learning objectives, teaching and testing points. So we triangulate the learning objective to the teaching and testing points. And what we do is, say we have a module on one topic area, say it's sepsis, and there's 7 activities in sepsis. There won't be one activity that's more than 15 minutes, and some of them might be 2 or 3 minutes, and some might be tools. Each individual is going to go through those activities based on where they have and lack mastery. So you can have the agency and go through each of the 7 activities if you wanted to, or you can get at the specific content that you are struggling with, that you're looking for, and you want an answer right now before you go into that patient room or right after you come out of the patient room. And so for that, you have the ability to access just the one activity within a 7 activity module. Does that make sense? And so that's how we're enabling people to get the content that is relevant to them at that moment. At another point in time, another activity in that module might be relevant to them, and they can go back and access it. And so that's truly what enables us to deliver personalized learning.
I would just add one thing. The platform is an increasingly important piece of the puzzle when you're talking about people's attention spans. And as been mentioned multiple times, the next generation has everything coming through the portal of their cell phone. And so one of the interesting observations with the COVID product has been the distribution of platforms that different learners are using, almost equally distributed between traditional computer, which even sounds odd to say, traditional computer, but something that's larger and has a keyboard versus an iPad versus a cell phone versus using the audio files or even accessing copies of the text and using that either as a primary or a secondary reference.
Yeah, specifically, on the COVID piece, we're averaging, everyone in South Carolina all providers in South Carolina have the product. So they're coming about 5.2 times a week. They're spending about 14.75 minutes in each session. About 50% are using it on their mobile, and they're giving us a 9.8 out of 10 in their overall satisfaction. Content relevance is 4.9, and the faculty effectiveness is 4.8. So pretty good stats for, a content that Dan has done a remarkable job really leading the clinical team and his faculty to make sure we're delivering exactly what's needed out there to make it just really quick and accessible.
Yeah, I'm going to remind everyone listening, if you want access to that free trial, you didn't complete the poll, or you're just listening on recording, you could go to sharedpurposeconnect.com/K2P, and we have a form up there right now. Just quickly fill it out. We'll get you registered for free, no credit card, nothing else, and you could get access to that COVID platform that Mary Ellen was just alluding to. As far as, I'm going to ask, and I'll throw it at you, David, and you could punt on it. It's not a K2P question specifically, but it's around patient-centric data and quality. And Jonathan asks, what measures are in place for the patient to share and consolidate information around physician education? I think what the listener is asking is there a way for the patient to know what educational access the physicians have?
That's a great question. There aren't any national measures, I could tell you that can guide patients. That's really kind of interesting. The closest thing would be, all of the somewhat questionable measures online, Yelp reviews, which are all basically process and related outcomes. Was the doctor nice? Did he or she communicate? Did I get my questions answered, et cetera, et cetera. But I'm not really, there's no other national measure on what educational tools doctors are using. I mean, it's kind of interesting.
Eric, it reminds me of a patient I had who, before she would let me treat her for the complications of her Lyme disease, quizzed me to see if I knew the genus and species of the offending organism, which fortunately I did.
Yeah, the spirochete. Yeah, that's a tough one. That sounds like attending rounds, Dan. Yes, it does.
How much of a challenge is training and education, and how much is it about data sharing and just the infrastructure in the 21st century that's missing here in healthcare?
Wow. Okay. So that's a really great question. Yeah, I'm not sure I know the proportion of each, but it certainly is a witch's brew. And here we are right before Halloween. How appropriate. Yeah, this is a witch's brew of stuff. There's no clear single issue here. This is maybe multifactorial is a good word here. A little bit of organization, a little bit of, going upstream to figure out where the leaders are, a little bit of no outcome, no income, a little bit of value-based payment, a little bit of performance improvement. I mean, this is complicated. That's why you need a tool, in my opinion, like K2P. I mean, as we said at the outset, there is no silver bullet, no single explanation. If there were, holy mackerel, you better believe we would have found it in the last 30 years.
Mary Ellen, you want to take a swing at it, or are you good?
No, I'm good. I knew he would cover that one out perfectly.
All right, very good. So we're closing in at the end of the session, everyone. I just want to, in advance, thank everyone for taking the time to, join us today. I never take for granted the hour you spend with us every episode. So we really appreciate it. We know you're really busy.